This is a video lesson on medical emergencies. An emergency is a situation in which the condition of a patient or sudden change in medical status requires immediate action. The objectives are to preserve life, avoid further harm to the patient, and obtain appropriate medical assistance as quickly as possible. The critical first step is for the technologist to be able to recognize which assistant might be warranted. Some general priorities include to ensure an open airway, control bleeding, take measures to prevent or treat shock, attend to wounds or fractures, provide emotional support, and continually evaluate and follow up appropriately. It's important for the technologist to be familiar with the location of emergency equipment, and that includes the crash cart or emergency cart. This is a wheel container of equipment and drugs typically required in emergency situations. Head injuries are important because we often see victims of head trauma in the radiology department. Even though diagnosing head injuries is not the responsibility of the radiographer, having knowledge of categorization is useful so that a basic assessment can be made and changes in a patient's status can be noted. So levels of consciousness begin with the least severe injury, and that's classified as alert and conscious. In most instances, this patient can respond fully to questions and other stimuli. A more seriously injured patient is drowsy, but can be roused to response with loud speaking or gentle physical conduct. An even more serious injury produces a patient who is unconscious and reacts only to painful stimuli. These patients do not respond to verbal stimuli, but react to stimuli such as pinches and pinpricks. The most serious condition is that of a patient who is comatose and unresponsive to virtually all stimuli. The technologist should quickly assess a patient when the procedure has begun so that it is readily noticeable if the patient deteriorates from one level of consciousness to another. The findings in an alert or drowsy patient that signify deteriorating head injury include irritability, lethargy, bradycardia, and bradypnea. The appropriate response to deteriorating situations would be the first priority is maintaining an open airway. The technologist should stop the procedure and medical assistance should be quickly obtained. And finally, we should obtain vital signs while waiting for help. Shock is a general term that indicates a failure of the circulatory system to support vital body functions. There are 4 categories of shock. The first is hypovolemic. This is caused by loss of blood or tissue fluid. This would be an example of a patient comes in with an emergency situation from a car accident. Cardiogenic shock is often caused by a variety of cardiac disorders, including a myocardial infarction. Neurogenic shock is caused by spinal anesthesia or damage to the upper spinal cord. And vasogenic shock is caused by sepsis, deep anesthesia, or anaphylaxis. Vasogenic shock is the one that we're most likely to encounter with contrast media reactions. However, the 2 types of shock that are most commonly encountered in radiology or encountered by the technologist would be the hypovolemic and vasogenic shock. There are contributing factors to a likelihood a patient will experience shock or to the degree to which shock will be experienced. The first factor is a change in body temperature, which makes it important to keep patients covered to maintain normal body temperature or to avoid overheating the patient. Also equally important is to consider pain, stress, and anxiety because they can really contribute to the development of shock. Preventative measures for shock would be, first of all, to maintain body temperature for your patient by either covering them or to avoid overheating them. Secondly is to be sure to provide emotional support to your patient. Third is to minimize pain. Next is to handle patients gently, which goes along with minimizing pain. work calmly and confidently, and finally, think and act appropriately, because all of these things can contribute to a patient's overall physiologic well-being. Signs and symptoms that a patient might be going into shock include restlessness, apprehension, or general anxiety. Tachycardia with hypotension, notice it's rapid heartbeat with low blood pressure, cold clammy skin, and pallor. If you notice that or believe that a patient is going into shock or the situation is developing, you should stop the procedure, ensure maintenance of the patient's body temperature, call for medical assistance, and measure vital signs while waiting for assistance. Anaphylactic shock is also called anaphylaxis. This is a type of vasogenic shock. An example in radiology will be where there's been administration of iodinated contrast media intravenously to a patient, and we would call these contrast media reactions too. The reactions can range from mild to severe, but most severe reactions will occur rather quickly, a rather quick onset. Generally speaking, the longer it takes for a reaction to develop, the less severe it is. Since severe delayed reactions can occur, it is important to constantly monitor patients who have had contrast media injections. There are three categories of acute reactions to contrast media, and they include mild, moderate, and severe. The mild signs and symptoms are self-limited without evidence of progression. The mild reactions include things like hives, limited hives, itchy, scratchy throat, nasal congestion, things of that nature. They oftentimes require observation, but there's usually no treatment. Patient reassurance, however, is usually helpful. Moderate categories of reactions include things like diffuse hives and itching, or diffuse erythema, even facial edema without difficulty breathing. Those are just a few examples. So clinical findings in these moderate reactions usually require prompt treatment. They require close, careful observation and for kind of watching for any possible progression to a life-threatening event. On the other hand, severe reactions are going to be those that could be life-threatening. And these are something that require prompt recognition, aggressive treatment with manifestations and treatment frequently requiring hospitalization. Let's talk about diabetic crises. Now, hypoglycemia could involve a patient who's diabetic or may not. The cause is an increase or excessive insulin. The symptoms for this individual would be intensely hungry, weak and shaky, and may sweat excessively. They also may become confused and irritable, sometimes to the point of aggression and mild hostility. The action for this patient would be they would need a quick form of carbohydrate. Hypoglycemia could result in insulin shock, and if a person becomes unconscious, immediate medical attention is required. Hyperglycemia is a condition of excess sugar in the blood, and it's typically associated with diabetes. The symptoms are going to occur gradually, so it could be a periods of hours or days, so it's not likely that you're going to see this, but these patients would be excessively thirsty and they would have excessive urination. They would have dry mucosa, rapid and deep breathing, drowsiness, and confusion. Sometimes you can smell a fruity smell on their breath, fruity odor on their breath. The patient needs insulin. If this condition is thought to be present, the technologist should get medical assistance. This condition can result in a diabetic coma. These diabetic crises can be something that we encounter or can be of concern to us as technologists. Patients who are required to fast should be questioned whether they have diabetes and which types of meds are taken. Our GI prep requires fasting, and sometimes if they fast and they've taken their insulin, it can result in a hypoglycemia. So diabetic patients should contact their physician for specific instructions, and also we should schedule these procedures first. Let's talk about some medical emergencies. The first one we'll discuss is asthma. Asthma attacks are often triggered in asthmatic patients when they're exposed to stressful situations, which could occur in a radiology department. They'll generally exhibit wheezing as a result of dilation of the bronchi on inspiration and collapse on exhalation. The technologist should stop the procedure, assist the patient to a sitting position to support easier respiration, and attempt to reassure the patient. If the patient has their meds available with them, then the technologist should allow the patient to use them. If not, then medical assistance should be obtained. Number 2 is choking. It's important that we use the Heimlich maneuver in situations in which a patient appears to be choking. A patient should be asked, "Can you speak?" And those with partial obstruction could verbalize their problem, but those with complete obstruction would be unable to speak. This signal is the universal distress signal for choking. The Heimlich maneuver should be performed on a patient who is choking, and the procedure must be performed repeatedly 6 to 10 times or until the obstructing object is expelled. When we're talking about a typical adult or child, this should be the position in which we perform the Heimlich maneuver. For a pregnant patient, we would use chest thrust instead, and for an infant, there could be back blows and chest thrusts that are recommended. Cardiac arrest includes the sudden stoppage of cardiac output and relates to permanent oxygen damage or death if not treated. Because cerebral function is generally impaired if the brain is deprived of oxygen for more than 4 to 6 minutes, CPR should be initiated immediately on verifying that cardiopulmonary distress exists. But these procedures absolutely must be performed only after determining that true cardiopulmonary distress exists. The process we're going to use in guidelines for CPR includes CAB, and that is compressions, airway, and breathing. So chest compressions must be performed first. The initial process should begin with 30 compressions at a rate of 100 compressions per minute, followed by the establishment of an airway and rescue breathing. A CVA stands for a cerebrovascular accident. This can also be a stroke, or referred to as a stroke. The onset of a stroke may be sudden or may be developed gradually over a period of several hours. Warning signs include paralysis on one or both sides, slurred speech or complete loss of speech, extreme dizziness, loss of vision, particularly if only in one eye, and complete loss of consciousness. The symptoms are sometimes only temporary. If the technologist observes any of these signs or symptoms, even if they are only temporary, they should be reported to a nurse or physician. Nausea and vomiting may occur also in radiology department. Something with nausea and vomiting that's important to do is to instruct the patient to breathe slowly and deeply through their mouths, and patients tend to become calmer with this so that nausea and vomiting can be avoided. But if that doesn't work, of course, the patient should be positioned in a way in which the aspiration of vomitus into the lungs is not likely. An epistaxis is also referred to as a nosebleed. Patients should lean forward and pinch the affected nostril against the midline cartilage with digital pressure. If gentle pressure fails to stop the blood flow, a moist compress may also be applied, but will not stop most nosebleeds. If these are not effective within 15 minutes, medical assistance should be obtained. And sometimes the patient's nose has to be packed, which is shown in this picture too. Vertigo and syncope sometimes go hand in hand. Vertigo is dizziness and syncope is fainting. Oftentimes the vertigo is a precursor to syncope. The patient who experiences vertigo should be assisted to a seated or recumbent position, which prevents injury from falling as a result of problems with equilibrium. Syncope is often a self-correcting temporary state of shock and the result of lack of blood flow to the brain. The treatment is aimed at increasing blood flow to the head, so the patient should be assisted into a recumbent position with the feet elevated. Any tight clothing should be loosened, and a moist cloth can be applied to the forehead. And we know that with radiology, we sometimes encounter patients who have orthostatic hypotension, and they'll have the vertigo and syncope associated with that. So we just want to make sure we have our patients set up or stand slowly to prevent orthostatic hypotension. Seizures are a pretty frightening event, and they can range from mild to severe. An ARA is something that many patients who are going to have an impending seizure will experience, and this would be a physical or mental warning of such a seizure. A mild seizure is going to involve where a patient stares off into space for a brief period of time or has a brief loss of consciousness. Severe seizures, referred to as grand mal, are going to be characterized by involuntary contraction of muscles on one or both sides of the body. Really severe grand mals are important, that we really want to prevent the patient from being injured. And that's what your role is, to support the patient. You want to make sure that patient has an open airway, and after a patient finishes with a seizure, they could typically have some drooling that occurred, clean that off, of course. The patient might be disoriented or have no memory of the event either. You want to make notations of the seizure, whether it was one or two-sided, and provide that information, including the length of it, so that those pieces of information that you put in an incident report and make notations of are important for helping later management of the patient's seizures as well as their treatments. Falls are also important to take care of. We should attempt to minimize the physical impact of a fall to the extent possible and proceed with appropriate emergency actions as indicated by the patient's condition. Of course, some patients might have a minor fall where we just do an incident report, while others may need immediate assistance. They may have to be checked into the emergency room if they were an outpatient. Next is hemorrhage. Some patients are going to have wounds that they've had previously or during surgery, and such wounds may result in hemorrhage. We should make note of the condition of dressings. If they're clean when you started the procedure that becomes saturated while you're performing a procedure, attention is definitely needed. The saturated dressing should not be removed. You should apply direct pressure over the saturated dressing, preferably with an additional sterile bandage pressed against it. Clogging can take up to 10 minutes, so the pressure may have to be maintained for some time. Once the bleeding appears to be under control, the bandage can be tied or taped into place. When a bleeding wound is an extremity, that affected extremity may be placed above the level of the heart, unless there's some contraindication to that being done. The next thing are burns. There's times we have to perform a procedure on a patient who has a burn, and we'll find that because burns disrupt the normal protective function of the skin, it's important to maintain sterile precautions on patients. First degree and second degree burns are painful, so we want to make sure we use extra gentle handling with these patients. And the next medical emergency involves dehiscence. Wound dehiscence is uncommon but can occur. It refers to a situation in which a patient's sutures separate, allowing abdominal contents to spill out of the peritoneal cavity. We should never attempt to replace the tissues inside the wound, but a sterile dressing should be used to cover the area. The patient should be placed in a seated position, somewhat bent forward to relieve any additional pressure on the wound, and get medical attention as quickly as possible. So I thought these pictures might be helpful looking at dehiscence and also kind of looking at the difference between dehiscence and evisceration. The actual organ can be ejected from that area also, so do not place anything back inside the patient. That area, whether it's dehiscence or evisceration, needs a sterile dressing over top of it. Then you get medical assistance. Fire safety is our final topic in this video lesson. There are three elements that must be present for a fire to burn, and they include a flammable substance, such as fuel, oxygen, and heat. And of course, fire can be avoided by ensuring that these three elements never occur in the same place at the same time. Once started, a fire can be stopped if one of the elements is removed from the situation. Most hospital fires are traceable to one of four causes, and the first one is spontaneous combustion. This occurs when a chemical reaction is in or near a flammable material that causes sufficient heat to generate a fire. This is pretty uncommon in hospitals because of state and local safety regulations, but it could occur during renovations or when paint products, solvents, and cleaning rags are stored in a closed environment or too close to a heat source. The second one are open flames. These are open flames that burn out of control that are pretty common in homes, but relatively few hospital fires begin this way. If they do, they've begun in kitchens or laboratories where open burners are used. The third is smoking. Smoking has been essentially eliminated in hospitals and is seldom a potential cause of fires. The fourth one is a potential source of fire hazard and is of special concern in radiology departments where there's much electrical equipment. For this reason, we emphasize avoiding electrical hazards and preventing electrical fires. If there's any suspicion that a fire hazard from an electrical malfunction has occurred, turn off the electricity at the main power source, call for qualified assistance, and stand with the proper fire extinguisher. So there's some electrical safety rules that are included. First of all, any equipment that we have must be approved for hospital use. We have to follow manufacturer's instructions. Any equipment must have grounded plugs. We need to inspect the equipment regularly, including the cords and the plugs. Do not overload circuits, of course. Unplug or turn off electrical equipment before exposing internal parts. Do not attempt to repair equipment unless you are trained to do so. Only use extension cords approved for the extended purpose. In case of an electrical fire, be sure to use a Class C or a carbon dioxide fire extinguisher. In the case of fire, remain calm and remember the acronym RACE. R stands for rescue. This is we're going to first of all make sure that we coordinate with personnel to remove patients from danger. A stands for alarm, and that's what we call the hospital code for fire. C is contain. It's to contain a fire by any means possible, which may include turning off electrical circuit breakers. And E stands for extinguish or evacuate. Fires are classified according to the type of fuel involved. Class A fires include solid combustibles such as paper or wood. Class B fires would include flammable liquids or gases, and Class C fires are those that include electrical equipment or wiring. Some examples of fire extinguishers would be water and foam would be great for Class A. Carbon dioxide could be used for Class B or C fires. And dry chemical could be used for Class A, Class B, or Class C fires. With fire extinguisher use, you want to be sure to first pull the pin. Secondly is aim the nozzle at the base of the fire. S is to squeeze the handle. And the second S is to sweep. Use a sweeping motion from the side to side to prevent the spread of fire. In this video lesson, we've reviewed information about head injuries, shock, some examples of what can occur in diabetic crisis and how to treat our patient, medical emergencies, as well as fire safety. Have a great day.